Shall we start, sir?
Yes, sir. Yes, ma'am. Please go ahead.
Very good evening and warm greetings to one and all from Maha IIP and Maha IIP Women Committee 2024. Myself, Dr. Manjusha Sherkar, Chairperson Maha IIP Women Committee, and Dr. Grivita Raikar, Co-Chairperson Maha IIP Women Committee, are going to moderate today's very first program named Wednesday Wisdom. Today's CME is on theme based, and today's theme is congenital infections and its implications in neonatal management. Friends, it gives me immense pleasure to welcome respected President Maha IIP Dr. Ram Gopal Chechera sir and Honorary Secretary General CIP EB Dr. Amol Pawar sir. I welcome distinguished chief guest National Vice President IIP South Zone Dr. M. Singaravelu, Tanjavur, Tamil Nadu. Welcome you, sir. I also welcome guest of honor, President Maharashtra NNF, Dr. Sanjay Ahir, sir, from Nasik. Welcome our today's expert mentors, Dr. Ashish Mehta, sir, Senior Neonatologist from Ahmedabad, and Dr. Om Prakash Jamadar, sir, Senior Neonatologist from Navi Mumbai. Welcome Dr. Milind Bapat, sir, Senior Pediatrician from Dahanu, as today's MMC observer. Friends, please note, MMC has granted 1 MMC point for today's webinar. So to avail this point, you all need to write your name, central IIP number and MMC registration number in the chat box. I welcome Dr. Mohan Warke, Treasurer Maha IIP 2024. I also welcome Dr. Bhavesh Mithia, sir, being the scientific convener of Maha IIP 2024. Welcome all the dynamic speakers and my best wishes to everyone. I also welcome Dr. Jitendra Gavane, sir, to be present for today's webinar. I welcome Dr. Amrita Baviskar, Women Committee Convener, and all my zonal Women Committee members who all are very enthusiastic to support the Women Committee. Welcome all the national OBs, EBs, and all the delegates who have joined in large number. Welcome Pallavi ma'am from IIP office. At the outset, let me thank Dr. Ram Gopal sir and Dr. Amol Pawar sir for forming a dynamic team of Women Committee and giving us an opportunity to serve the State Pediatric Society. We are fortunate to get huge inspiration from the past Women Committee. In 2022, headed by Dr. Renu Goralkar as a chairperson and guided by Dr. Hemant Gangolia sir as a president, along with Dr. Amol sir as a secretary. Also in 2023, we got inspiration from this team under the leadership of Dr. Sonali Shirbhate, my friend, as a chairperson, and Dr. Ramakant Patil sir being the president and Dr. Amol sir as a secretary 2023. I hope we all could reach the bar which was set very high in our previous sprints in Women Committee. Friends, before opening the scientific program, I request our president, Dr. Ram Gopal sir, to have a few words with her. Over to Dr. Ram Gopal sir.
Good evening, friends.
Pallavi ma'am, 1 minute, Ram sir. Pallavi ma'am, some echo is there. It is disturbing it.
I'm searching for that, but no one's is voice is on apart from your all like.
So
I'm
please,
searching
sir.
Dr. Nityanand Chikhalkar. I think that is the only one which
No,
needs
no,
to
ma'am. No, ma'am. His mic is not on. His mic is not on.
So anybody from co-host, host have joined from 2 devices.
No, we can make all mute and then unmute the speaker only.
Pallavi ma'am, can you do?
That already been done, sir.
Done? Okay. We'll start then. Ram sir, please.
Am I audible?
Yes, sir. Yes.
Yeah. So, good evening, everyone. Respected today's chief guest, Singarvelu sir and Dr. Sanjay Iyer sir. This is the first program of the MahaAP, and in that I welcome all my MahaAP team and our EB member Dr. Jitendra Gawane. As you have heard, we always say ladies first. So even the presidential action plan has started with ladies first. So congratulate to the ladies wing that and the last 10 days they have taken a lot of efforts to design and implement the program. So thank you, the chief guest, and I welcome our experts, Dr. Ashish Mehta and Dr. Om Prakash Jamdar, and today's presenters. Once again, congratulations to the women's team, and I think we are already getting late, so we can start the program as early as possible.
Thank you, sir, for your generous welcome. Thank you, sir, and support also. I like to share a few words from Dr. Amol Pawar, sir. Over to you, Dr. Amol Pawar.
Thank you. Thank you, Manju ma'am. First of all, welcome today's chief guest, our dear friend, one of the senior vice president, Dr. M. Singarvelu sir. He is a vice president from South Zone. Then next, my dear mentor, friend, is president of NNF, Maharashtra NNF, Dr. Sanjay Iyer sir, today's guest of honor. Then we are fortunate to have Dr. Ashish Mehta, a senior neonatologist, one of the famous names in neonatology, to be with us as an expert to guide our speakers, and also senior neonatologist, Dr. Om Prakash Jamdar sir from Navi Mumbai. We also have all the speakers from all parts of Maharashtra. So Dr. Tanushri Mukherjee is there from Mumbai. Then Dr. Deepa Joshi from Nashik, Dr. Ajay Jadhav from Bid, then Dr. Bhushan Thorat from Amravati, and Dr. Shilpa Kalani from Pune IIP. So these are the speakers. These are the young speakers from all over Maharashtra. This is actually an initiative put forth by Dr. Renu Boralkar 2 years back under the presidentship of Dr. Hemant Ganguly and myself as secretary. And it was started as Tuesday Takes, but somehow this year we are continuing with it as a Wednesday Wisdom with some changes designed by scientific convener of Maharashtra IIP, Dr. Bhavesh Mithia sir, under the guidance of President Dr. Ram Gopal Chejara sir and whole team Maharashtra IIP. So this year, under the chairmanship of Dr. Manjusha Sherkar, then co-chairperson Grivita Raikar ma'am and convener Dr. Amruta Bhaviskar ma'am, these three will be heading this MahaAP Women Committee this year, and there are 10 zonal executive board members from all parts of Maharashtra, Western Maharashtra, then Mumbai and Konkan, North Maharashtra, Vidarbha and Marathwada. So 2 zonal members from each of these zones will be helping them out to design various activities under Maharashtra IIP Women Committee, and this is one of the activity that is Wednesday Wisdom. Dr. Bhavesh Mithia sir has designed all these today's theme congenital infections, and he's designed 5 topics, so which will be helpful to all the general pediatricians also in their neonatology practice. So once again I welcome all the delegates, all the executive board members of National IIP, Maharashtra IIP, then all the OBs of various district branches also. And today's MMC observer is Dr. Milind Bapat. MMC have sanctioned 1 MMC credit point to this webinar. So I request all the delegates to put their MMC number as well as IIP membership number. Those who are IIP members, these delegates only will get the 1 MMC point. And almost I'm surprised to see 160 was the number at the start of the at 902, exact 902, and now it is 210. So this speaks about the success of this program. So I congratulate all the speakers again. for taking agreeing to be as a speaker for today's webinar, and wish you all the best. And over to you, Manju ma'am. Thank you.
Yes, thank you so much, sir. Amol sir, Ram sir. We want to make this program most popular only because of your rock consistent support. Thank you so much. I forgot to welcome Dr. Satish Sahane, sir. Welcome, sir. And I request now my co-chairperson, Dr. Grivita Raikar, for further proceedings. Over to you, Grivita.
Thank you so much, ma'am. On behalf of the MahaIP Women's Committee, I welcome you all once again. It gives me immense pleasure to welcome our chief guest for the evening today, Dr. M. Singaravelu, sir. Sir is a professor of pediatrics, VMMC Karyakal. Sir is IIP Vice President South Zone 2024, Vice President East Zone IMA Tamil Nadu State 2022, District Chairman Polio Pulse RI District 2981, President IAP Tamil Nadu, CIP EB 2016, 17 and 19. Sir is also the Mathuva Nachatra Award. Sir has been awarded the Mathuva Nachatra Award by the Hindu and IMA Tamil Nadu by Honorable Health Minister in 2021. Dr. Jairaja Ayya Nadar Oration Award by the IIP Tamil Nadu 2020. The Manamana Rajaran Award by Tamil Nadu government. The Best Teacher Award by Tamil Nadu Dr. MGR Medical University 2011, Best Doctor Award by Tamil Nadu State Government 2013, Best Doctor Award by the District Collector 2015, Best Doctor Award by the IMA Tamil Nadu State 2016, Best Doctor Award by the IMA Tanjaravu Branch 2017, Senior Pediatrician Award by the IAP TNSC 2017, Dr. Bala Goparaja Active Pediatrician Award by the IAP Tamil Nadu 2000. Dr. Saravapelli, Dr. Radhakrishnan Lifetime Achievement Award for the Best Teacher by IMA TNSB 2022. I welcome you, sir. May you please share us with your few words of wisdom.
Good evening to all. At the outset, I wish you all a very happy and prosperous New Year 2020-24. With regards to our National President, Dr. Basavaraj Sara, I'm very happy to be here with Maha IAP Academy. Thank you, Grivita Madam, for your nice introduction. At the outset, I should thank the initiative taken by the Maha IAP with the Presidential Action Plan by the President, Dr. Ram Gopal, Secretary General, my good friend, dynamic person of our National IAP, and joint national coordinator of our Presidential Action Plan of our National President 2024. The moment of respect you people having with him, I could really enjoy that. Our National IAP, to have a person like Amol as your secretary, we are all very proud. Thank you, Amol sir, for giving me this opportunity to be with you today evening. And our dynamic another member, Jitendra Gavane, who is also be a dynamic person and pillar of our National IAP, who is with you, and your treasurer, Dr. Mohan Varghese, and very dynamic women being, very proud, in fact, happy to see you. Very active. See, in the night, 230 people have joined in this webinar. Of really hats off to the chairperson, Manjusha ma'am, co-chairperson, Grivita ma'am, and our scientific convener and our chief guest, great person, Ashish Mehta, Om Prakash sir, and other members, Amurtha ma'am, and the great speakers today's topic, because I don't want to tell each and every name I don't waste your time because a lot of wise topics. But I'm very proud that you have taken up a topic of very much needed for the practicing pediatrician. Not only it is not for neonatologists, for physicians also to know about it. So definitely it would be that congenital infections. See, in my days when I was doing my PGs, 80s and all that, we heard the term about TARCH, where we know about toxoplasmosis, cytorubella, cytomegalovirus, only herpes simplex. Then it was expanded in 90, where syphilis also included. Now so many, starting from Zika virus, HIV was in the peak in 90s and 2000. Of course, it has gone reduced. Actually, the statistics says around 2% of total infection. But many in our India, it should be more than that, which may be unnoticed because of a lot of miscarriages, abortions, and IUDs happening because of all this. Definitely, it is a topic to be discussed for practicing pediatrician because it is really good topic and you have chosen speakers, very good speakers. I'm really proud that the ladies wing of Maha IAP Academy under the leadership of Madam Manjusha and the President Ram Gopal and our dynamic secretary Amol and Jitendra and all other central EP members and today's guest of honor also being a neonatologist Sanjay Ajar sir. I'm very happy, being honored to be with you all. And thank you for giving me this opportunity to be with you. And I'm sure that always Maharashtra, whatever in our IAP, stands always in the top. And the moment of interest that ladies wing is doing a very good academic activity of and being a Wednesday wisdom. We are really proud and honored that, and being the first meeting I have been with you all, I wish and pray that your academy will go further and further and give a lot of inputs, both academics as well as you should also reach community because you had a very vibrant team under the leadership of our dynamic secretary and Jitu, who can bring a lot of inputs from National IAP. And on behalf of our national president, I'm sure that we will be supporting you in all your endeavors and we will wish that Maha IAP grow further and further and the women empower. We always talk about women empower. Definitely, it is a great thing what Maha IAP has done. I am really honored and very happy to be with you all and wish you all the best and wish this academic event will be a very successful, very fruitful, useful to the practicing pediatrician and others. And once again, I thank all of you for giving me this opportunity to be with you. Thank you, ma'am. Thank you. Wish you all the best. Thank you.
Thank you,
Thank
sir,
you.
for your kind words of wisdom. Now, welcome our guest of honor, Dr. Sanjay Ahere, sir. Sir is a medical director and owner of North Maharashtra's most advanced NICU, the NeoCare Hospital, Nasik. His major achievements being Cochrane reviews on erythropoietin in neonates, 14 journal publications in renowned national and international journals, President SCNNF Maharashtra 2024-25, Organizing President Mahaneocon 2019 Nasik, President Nasik IAP 2019, National Faculty for various neonatal conferences. I welcome you, sir. May you please share your few words of wisdom with us. Dr. Sanjay Ahere, sir.
Yeah, good evening, everyone. And I thank Maharashtra IAP for inviting me for this today's program. And special thanks to my friend, Dr. Amol Pawar. I will not take a lot of time because it is already 21:09. So we are eagerly waiting for all the young speakers to listen from them. And thank you for choosing such an important topic because we treat so many neonates with infection and sometimes we get stuck. What could be the diagnosis? And now I think we are going to learn from all these speakers how to diagnose these problems. And I also thank the expert, Dr. Ashish and Dr. Jamadar. So thank you, Maha IAP, for inviting me for today's academic program. Thank you and all the best to all the speakers. Thank you.
Thank you, sir. With this, moving on further, I take the pleasure to introduce our guest experts for today. Dr. Ashish Mehta, sir. Sir is the consultant neonatologist, Arpan Newborn Care Center, Private Limited, Ahmedabad. and Dr. Om Prakash Jamadar sir. Sir is presently working at Apollo Hospital, Navi Mumbai as consultant neonatologist and pediatrician. We welcome you, sir. Moving on further, I also would like to welcome our MMC observer, Dr. Milind Bapat, Dr. Jitendra Gawane sir, Dr. Satish Shane sir, and all the dignitaries on stage, present here. Thank you. Moving on further.
Dr. Om
Give it a minute.
Prakash. Dr. Om Prakash sir.
Dr. Milind Bapat sir will have some words with us. Milind sir, please. MMC observer.
Hello, I'm Dr. Milind Bapat. I'm a practicing pediatrician from Dahanu. I'm very thankful to Maharashtra Medical Council for appointing me an observer for such a great program of such an esteemed organization. Otherwise, also as a pediatrician, I have attended Maha-IIP programs, and they are really very informative for a pediatrician working in Maharashtra rural setting like me. So I wish everybody all the best, and I thank Dr. Ram Gopal, Dr. Amol Pawar, and all other dignitaries. They are really bringing up very good programs, and I look forward to all the lectures. Thank you.
Thank you so much, sir. So now, moving on further, we shall begin with the first speaker, Dr. Tanushree Mukherjee. Madam is consultant neonatologist and pediatrician, Cloud9 Hospital, Malad. The first topic being congenital toxoplasmosis. Over to you, Dr. Tanushree.
Dr. Tanushree.
Yes. Yeah.
One minute before
Yes,
starting.
sure.
I would just request Dr. Jitendra Gawane, he is our EB member, to speak a few words before we start. Unmute.
Unmute. Jitu sir, unmute. Pallavi ma'am.
Oh, sir.
Pallavi ma'am, Dr. Jitendra Gawane.
Yes, yes. Jitu sir,
Yeah.
तुम्ही करू
Good
शकता.
evening. Without wasting time, I think we should start. I give my best wishes to Women's Wing of Maharashtra, and special thanks to Bhavish Mithia sir for designing excellent scientific program for this year 24. We will unveil its coming programs in further week, and you will be surprised to see the amount of work planned, and at center Basavaraja sir, and at state Ram Gopal. So it is going to be a tough job for all viewers and fellow pediatricians also to attend those beautiful words. So I request Amol sir to record all sessions whenever possible and keep posting in the link, YouTube link. And special thanks to Manjusha ma'am for taking first Women's First program. Otherwise, I was thinking that on Ram Janma Bhumi inauguration, first program will come. So best wishes to you, everyone. Thank you.
We are having already more than 250 attendant participants. So now you can start, Dr. Tanushree.
Thank you. Thank you so much. First, I would like to thank the organizer for giving me this opportunity to talk today with so many senior teachers and colleagues, and I feel really privileged today. So the first talk is congenital toxoplasmosis. As we all know that it's an obligate protozoal infection, and the definitive host being the cat. So once the cat is infected, it secretes lot of oocyst in the stool, and then the intermediate host comes. So a lot of the other animals, even the human beings. So if the soil and the water that is infected with the oocyst, it digested, and the tissue cyst that is there inside the muscles of this intermediate host, that uncooked meat is ingested by the human beings, that causes infection to the baby. So the cat being an definitive host, sometimes it can extract almost 10 million oocysts per day for 20 to 24 days. So that's a huge burden of disease. Now, it depends geographically, as well as in the same geographical region also, it depends according to the different like eating habits and the sanitation practices of those people over there. The other mode of infection is the transplacental infection, and rarely by the organ donation. So as we now know, this is the type of infection that we have. So we have a few idea about how to prevent it. So definitely by the washing of the vegetables, properly cooking the meats and everything. And specifically for the people who have pets at home, like cat, and if the lady is pregnant, special precaution should be taken that if they should not handle the cat litters, even if they are handling, proper uses of the gloves and masks should be there, and wearing gloves and washing the utensils and everything. So pathophysiology of congenital toxoplasma, that starts with maternal infection that happens either just before the delivery or reactivation of the disease during the time of the pregnancy, either if the mother is HIV positive or some immunosuppressant therapy. The placental infection happens after the mother is infected, causes placental infection, and there is a gap of around 14 to 16 weeks that we call as a prenatal incubation period, and that is a very important importance on the therapeutic intervention that we do during the pregnancy, which antibiotic we treat, whether that targets the placenta or whether that targets the fetus. So now the rate of infection depends on which trimester the mother is getting infection. If it is first trimester, the rate of infection is less, but the severity of the infection is much more. So it's almost 60 to 70% babies can have a severe disease, with almost 30 to 35% with a stillbirth or perinatal death, lot of miscarriages and abortions. Now, second trimester, it's hardly 30 to 40% of the babies that get infected. Third trimester, almost 60 to 70% babies get affected. But out of that, almost 90% are either asymptomatic or mild diseases. Now, coming to the clinical features, as I told, majority is asymptomatic disease or mild disease. The babies who present with the clinical features, out of that, 2/3 is a CNS involvement. And the classic triad of congenital toxoplasma, what we see is chorioretinitis, intracranial calcification, and the hydrocephalus. Out of that, chorioretinitis is the most common. That happens almost 86 to 90% cases. And it is a disease of evolution. So the patient maybe at birth, they may not have it, but that can develop in the infancy, in the early adolescent age, even in the later adult phase also. So, and this is, sometimes it can present as a simple blindness, iridocyclitis, or simple strabismus as well. Now, intracranial calcification can be either single or multiple. It can be very diffuse as well. Hydrocephalus, mostly because of the obstructive hydrocephalus, because of the periventricular obstruction. Around 1/3 present that comes with the reticuloendothelial system involvement, and that can be with any other congenital infection with temperature instability, systemic symptoms, hepatosplenomegaly, jaundice, pneumonitis. And if we do the complete blood count, there will be anemia, thrombocytopenia, as eosinophilia. So the diagnosis of congenital toxoplasma mainly depends on the polymerase chain reaction. And in fetal life, we can do the amniotic fluid test. The gestational age, at what time the mother has the infection, has a significant influence how the PCR positivity we detect. Normally, the yield is high when it detects after fifth week of maternal infection. Normally, we do it around 17 to 18 weeks. Again, that prenatal incubation periods, comes here, because once the baby is infected, then only we will get to see the amniotic fluid PCR studies positivity. And negative PCR doesn't rule out fetal infection. So if the mother has an infection from 17 weeks to 21 weeks, definitely it won't get on the PCR positivity. Now, once the baby is born, we can do neonatal, the different body fluid tests, like it can be a blood, urine, CSF, we can do. And CSF test along with the serology test gives us the more sensitivity. Now, as we know that once the baby is infected or anybody is infected, the first antibody that we have is an IgM, and that plateaued around 1 month and then goes down. The second antibody that what we have is the IgG titer, and if we don't treat with an proper treatment, that can stays there. So Toxoplasma, once infected, it gives lifelong immunity, and with the different pattern of serology titer, what we can see that we can use to detect the Toxoplasma infection. So this is the infection that what we can do during the time of the pregnancy. So normally we should do that diagnosis in the first trimester, because Toxoplasma infection is a very time sensitive infection. So unless we detect early, we won't be able to start treatment, specifically the antibiotic treatment early in the mother. So if the mother is IgM, IgG negative, infection is not there. If the mother is IgM positive but IgG negative, we should reassess after 1 to 3 weeks. Now, if the mother is IgM and IgG both positive, it is a suspected infection. Now, once we know IgG, that I have shown with the previous slide, we don't know exactly what stage of disease it is. It's very important to identify whether it's an acute disease causing IgG raised or it's a chronic disease. So here we do the avidity test. So the basic concept of avidity, that if the disease is a primary disease at the early phase disease, the affinity or the avidity of the antibody to that particular antigen is low. So low affinity is an acute infection or primary infection. High avidity is a past infection or chronic infection. Now, if we have a report that is in between low and high affinity, so it's an inconclusive thing, and we have to reassess the mother after 1 to 3 weeks. Now, if we have some scenario that is IgM negative and IgG positive, it can be a possible infection. Now, there is another test to differentiate the acute and chronic infection from IgG, that can be because of the IgG differential agglutination test, that can be also used. Now, what about the baby? Now, the baby is born. So in baby, we do the paired serological test. It has to be done from a peripheral smear, not from a cord blood. And we do amniotic fluid PCR and the IgG, IgM, and different Western blot, ELISA, and ISAGA test. So if everything is negative, as of now, the baby is not infected, no therapy is requirement. But the baby has to be followed up every 3 monthly till 1 year. So why 1 year? Because the maternal transplacental antibody that is present in the baby till 9 months to 1 year life. So if it is negative by 1 year, that is seronegativism, that baby is no infection, no need of treatment. Now, if that antibody IgG doesn't decrease, or if there is an increase in the antibody, now this baby is infected. The other line of this is very straightforward, that amniotic fluid PCR positive and the baby is serology positive. So this is an infected baby and we should treat that baby. The other test what we can do is a cranial sonography. As we all know, the hallmark is hydrocephalus, calcification of the brain, spleen, liver, hepatosplenomegaly, ascites, that can present even in the fetus as well and in the later life. Histopathology or inoculation test is not a very common test, because inoculation takes almost 4 to 6 weeks in a mice in a laboratory. So it doesn't give us a much of yield when we are actually treating that patient. Histopathology of the placenta also helps a lot. Ophthalmology test is a very important test, because chorioretinitis that evolve over the time, and regular ophthalmological test every monthly, then every 3 monthly till the baby is 18 months old, then every 6 monthly to 1 year till the person is 18 years old should be done. Hearing test, because we know that congenital toxoplasma is one of the reason of sensory neural hearing deficit. So OAE beta that we should do. CBC and LFT as a routine, as well as to monitoring for the drug therapy. Yes.
We are finished with 10 minutes.
Another 2 slides.
2 more 2 minutes.
Yeah. And CT scan. So this is how to treat the mother. So if the mother is detected less than 14 weeks, start on spidermycin. This is a treatment against your placenta. So do an amniotic fluid sampling at around 14 weeks. If it is positive, the fetus is positive, of having some fetal ultrasonography features, shift to pyridoxine and sulfadiazepine. If the mother is treated after 14 weeks or after 18 weeks, directly start with pyridoxine and sulfur dioxide. If it is negative, the negative PCR and the negative serology, switch over to spironolactone, or if it is both the positive, we can continue with the pyrimethazine and sulfatazine. Coming to the treatment therapy in the newborn, once the baby is born, all asymptomatic patient and the symptomatic patient should be treated, and the treatment should be for 1 year. We should start with a prednisolone or oral steroid if the patient is having some active chorioretinitis or if the protein exceeds 1 gram. So normally this treatment, steroid treatment, started 72 hours after the proper pyrimethazine and sulfadiazepine treatment has been started. Long-term treatment of 1 year has been associated with decreased incidence of newborn morbidity, better neurocognitive milestones, better auditory and the better ocular milestones. The monitoring should be done with a CBC, any level that is absolute neutrophil count less than 800. We should stop the therapy temporarily, continue folinic acid, and then we can restart once the ANC level is more than 800. So this is my last slide, or the summary of the slide that I have taken from AIIMS 2019 protocol, and that has beautifully summarized that how to treat the spironolactone, pyrimethamine, and once the baby is there, to follow up the baby till 1 year. The babies who not infected, no need of requirement, but emphasis on asymptomatic congenital infection and the congenital infection to treat with 1 year of therapy and a regular follow-up. Thank you so much.
I request Ashish sir to please give his quick reviews on this case.
Yeah, basically, quickly, I can say that this is a disease which is preventable. If not preventable, then treatable. The basic person, the culprit is cat.
Sir, you are mute.
Ashish sir, you are not audible.
We can't hear you. We can't hear you, sir. Dr. Ashish. Ashish sir, we can't hear you.
He is not muted actually.
He's not
Ma'am,
muted.
actually, he has some audio issue, ma'am. Ashish sir,
Ashish sir.
can you?
Maybe we can just give him a call and then.
I'm just giving you a call.
Can you call him?
Yeah.
Yes, sir.
I just gave him a call, but I think
I would try once more.
Amol, can you call him?
Yes, sir, we are calling. Okay, sir.
Tell him to log out and log in again.
Yeah, sir. He's doing that.
In the meanwhile, can we request Dr. Om Prakash sir to give a quick take-home messages? Dr. Om Prakash sir? Sir, you are muted. You are muted, sir. Om Prakash sir, you are muted. Om Prakash sir, you are muted. Kindly unmute yourself.
Om Prakash sir, try now. Om Prakash sir, try now.
Yes. Now I am able to unmute because
Yes,
I was not able to.
Yes, sir.
So,
Yes, sir.
so it was good presentation in terms of the antenatal infections and then perinatal transmission. So the major thing that we should remember as a part of congenital infection is like this is the one infection which causes hydrocephalus. Rest of the infections, if you see all these TOSH varieties of infection, the microcephaly is a prominent part, but this is the only one condition where hydrocephalus is seen. Otherwise, she has explained it very well.
Ashish sir, please try once.
Yeah, yes, okay,
Ashish
yes.
sir, please try once.
Yeah, am I audible?
Yes, sir.
Yes,
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 sir.
so nicely
You are
mentioned, nicely presented by Dr. Tanushree. Basically, what we need to understand that we have to decide about the maternal infection, fetal infection, and neural infections. The cat is always asymptomatic, intermediate host is always asymptomatic, and baby or mother will suffer. Picking up the diagnosis for the mother is always a screening test of IgG and IgM. Before 18 weeks, it is not that easy. After 18 weeks, you can do that. And if you can treat in time, baby can be saved from getting infected with Toxoplasmosis fetus. I mean, once baby is delivered, then the definite test would be PCR or nucleic acid amplification test, NAAT. And this is definitive for the diagnosis. Now, IgG and IgM in the baby can leak through the placenta. So they are not that reliable. If you get the IgM positive in a baby, within first 15 days, that is always from the placenta. But after 15 days, ideally it should decline if it is from the placenta. If it is persistent after 15 weeks of the birth, after 15 days of the birth, that means it is from the baby and that is to be considered positive. IgG can leak through the placenta. Generally, it should disable by 6 months of the 6 months after delivery. So if IgG is positive and remains positive beyond 12 months, then again the baby is to be considered infected and that is to be treated. The good part of the treatment is that this is reversible disease. So if rightly treated, baby can be saved from the devastating effect like choroid retinitis and the ventriculomegaly related problems. Otherwise, everything was perfectly all right. Great, well done.
Well summarized, sir. Dr. Om Prakash sir and Ashish sir, thank you so much. Moving on further, I request Dr. Deepa Joshi to present the cases on congenital syphilis. Madam is an associate professor, Dr. Vasantrao Pawar Medical College and Research Center, Nasik. Over to you, Dr. Deepa.
Good evening, all. My topic is congenital syphilis. It is severe, disabling, and often a life-threatening infection which is seen in infants. About half of the all infected fetuses, they die shortly before or after the birth. So clinical manifestations will depend on the intrauterine and the postnatal stage. In the intrauterine, it affects the placenta, which causes a large edematous placenta, sometimes chorioamnionitis infection, and in the fetus, it can cause intrauterine death, stillbirth. The postnatally, the changes are divided as early changes and the late changes. In the early changes, the earliest sign is a syphilitic rhinitis, feeding difficulty, and extreme irritability in the infants. There is a maculopapular type of rash, which can be also vesiculobullous type, and later on it can causes the desquamation of the cell. Typically, it is seen on the palm and sole area. It involves the mucosal area also, oral mucosa, anal mucosa in the form of condyloma lata. And later on, as after the 2 years of age, the chronic changes or the late changes of syphilis are seen. They are in the form of Hutchison teeth, they are cone-shaped or peg-like teeth. Then there may be a long bone involvement in the form of osteochondritis or osteomyelitis like changes. They are very painful and pseudoparalysis of the legs are seen. The typical Wimberger sign is seen in the X-ray. There is an interstitial choroiditis involving the eyes. The long-term syphilitic rhinitis, which can snuffle formation causing a saddle nose. It in fact causes the septum of the nose to get perforated. So these are the long-term or the chronic changes of syphilis which are seen. Now coming to the diagnosis, the definitive diagnosis is by direct visualization of spirochetes using dark field microscopy or direct fluorescent antibody testing which are done on the lesion exudate or tissue like placenta or umbilical cord.
Now, coming to the serological diagnosis, which involve the non-treponemal test and the treponemal test. The non-treponemal test, as we all know, they are the VDRL, rapid plasma reagent test, and the treponemal test are various tests like TPI, that is treponema pallidum immobilization, fluorescent antibody absorption test, microheme agglutination test, CI, that is a chemical immunoassay test, enzyme immunoassay test. These are the various types of treponemal tests. Now, these non-treponemal tests, they have some false negative and false positive values. The false negative may be seen in case of early primary syphilis, maybe in late congenital syphilis. The false positive tests are seen in case of a viral infection like Epstein-Barr virus infection, hepatitis, varicella, lymphoma, tuberculosis, etc. These are going to give false positive result. So whenever we are doing a screening test, that is a non-treponemal test, it may be positive, it may be negative. That has to be followed for confirmation by treponemal test. Now, suppose the NT test is positive and the treponemal test is also positive, there is a high chance that this is a newly diagnosed case or either a previously treated case which is showing NT test in a decreasing titer. Then suppose the negative non-treponemal test is there, and along with that, you have a positive treponemal test that indicates early infection or maybe past infection, or also the false positive test which will come in case of other spirochetal infection like yaws, pinta, or sometimes in case of a leptospirosis also. Negative NT as well as negative treponemal test, both the tests are negative, so there is a high chance there is no infection in the baby. Now, positive NT, but there is a negative treponemal test is there. Such condition will arise in a biological false positive test, which we just recently saw in case of other type of viral infection or tuberculosis, malaria, or lymphoma-like cases. So, non-treponemal test, any NT positive must be confirmed by treponemal test to exclude the false positive. Sustained fold-fold declining NT test titers after the treatment indicate the adequate treatment given by the to the newborn. Now, this treponemal specific test, it confirms the NT test reagenicity. It remains positive lifelong. The results are not going to correlate with the disease activity, and these tests are not quantified. And it has also false positive reaction, as we already saw in case of other types of spirochetal disease or leptospirosis-like diseases. So coming to the CDC newborn evaluation, the Center for Disease Control gives a guideline for newborn evaluation. A presumptive diagnosis which result in a treatment is made if the baby has positive serological test and any of the following. That is compatible finding on primary examination, which we just saw, the clinical finding, CSF abnormalities, that is positive VDRL, increased WBC count or increased protein, osteitis of the long X-ray bones, placentitis, NT test more than 4-fold than that of the maternal levels, and positive fluorescent treponemal antibody absorption test. So once this mother is coming with the VDRL positive, how to approach this newborn and how to evaluate the infant. So mother with syphilis with a reactive VDRL, RPR, and confirmed by antibody testing, then we have to evaluate the infant. Assess the adequacy of the maternal treatment, pathological examination of placenta or umbilical cord, dark field microscopy of the suspicious lesion or body fluid, then the clinical examination of the infant for evidence of syphilis in the form of non-immune hydrox. It may be a cum-negative hemolytic anemia, jaundice, hepatosplenomegaly, rhinitis, different skin rash, and pseudoparalysis, and the quantitative VDRL or RPR, which is done on infant. Now, there are different case scenarios. We will go for case scenario. The first one is a proven or highly probable disease. So, presence of any of the one of the following, like first, physical abnormalities suggestive of congenital syphilis, or VDRL or RPR 4-fold higher titer than the mother titer, or positive dark field test of the body fluid. So here the evaluation is done for the CSF. We have to do VDRL, cells and protein. We have to do CBC, which will show the thrombocytopenia, anemia, leukopenia or leukocytosis. The other test as a clinically indicated like X-rays of the long bone, chest X-ray for pneumonia, LFTs, neuroimaging, ophthalmological examination for keratitis, and BERA. So the treatment here is a penicillin G. The dose will be 1 to 1.5 lakh international unit per kg per day to be given 12 hourly, out of which first 7 days it will be given 12 hourly, and then later on till 10 days it will be 8 hourly. Sometimes procaine penicillin can be given as a 50,000 international unit per kg per
Madam,
dose.
2 minutes more.
Yes, ma'am. I am in a single daily dose for 10 days. But as we all know, penicillin G has an adequate CSF concentration as this Treponema pallidum divides slowly. So this has a long-term action. So for neurosyphilis, the penicillin G will be the preferred choice of drug. There is no other drug apart from penicillin G, and up till now, there is no resistance to penicillin. Now, the second case is a possible congenital syphilis. That means presence of all of the three following. Here, the physical examination of the newborn is normal. The VDRL titers are less than 4-fold of the maternal titer. The mothers are not treated or inadequately treated or treated with the non-penicillin regimen, which is less than 4 weeks before the delivery. So the evaluation will be same as a case scenario 1, and the treatment is also same as above. Now, if here the second opinion of thought is like, if the follow-up is uncertain, or whenever there is the child is at a high-risk case newborn, then sometimes we can give this penicillin as a 10 days, but the evaluation is normal and the follow-up is certain. Sometimes we can give a single intramuscular dose of benzathine penicillin. Then the third case where we have a less likely possibility, the three of these criteria, like normal physical examination, the VDRL is less than 4-fold of the maternal titer, mothers are adequately treated during the pregnancy and more than 4 weeks before the delivery, and does not have any reinfection or relapse. So here actually no evaluation of the baby is required, and benzathine penicillin G 50,000 international unit per kg as a single IM dose may be considered, particularly if the newborn's follow-up is uncertain. And the last case, which is congenital syphilis unlikely, that means the baby is having complete normal examination. The VDRL titers are less than 4-fold of the maternal titer, and here the mother is adequately treated before the pregnancy and her titer remained low, stable before, during, and at the time of delivery. So no evaluation required. Similarly, as a case 3, actually no treatment is needed, but some thought of opinion says a single IM dose of benzathine penicillin G. Now coming to the last slide, where it is the follow-up of the newborn of treated congenital syphilis. Whenever there is a reactive non-treponemal test, we have to repeat these titers 3 monthly unless it becomes negative. So retesting done at the 6 months, if shows still positive titer after treatment, then we have to reevaluate with the CSF, and the retreatment with penicillin G is recommended. We have to document normal CSF. If the retesting at 6 months shows declining titer, that indicates the child is recovering, and the titers which are non-reactive at 6 months, then that newborn is labeled as a cured. So the congenital syphilis, here the maternal as well as newborn screening is needed. The mothers are screened before the pregnancy, during the pregnancy, at the time of delivery, as whenever the mother is going to come to you, and the newborns are screened immediately and started on treatment. Thank you.
Dr. Ashish Mehta, sir, may you please give your expert comments?
Yeah, basically, see, this is a disease which is where the newborn will be mostly normal. Generally, doesn't happen in first few weeks of the life. You don't see the baby with congenital syphilis within first maybe 15 days or 3 to 4 weeks. It generally appears within 3 months of life. So it is the second and third month where you feel some abnormality like prolonged jaundice, HS megaly, anemia of unknown origin, baby not thriving well. And then if you look into detail, you find all these eye and bone abnormalities. So it is not an immediate diagnosis, number one. Number two, in current era, good number of obstetricians have stopped doing VDR in mother. So if you look at the CDC protocol, no baby should be discharged without knowing maternal VDRL status. That is what even Cloart is written. And we need to make sure while attending delivery that mother's VDR is being done. If not, we and baby is not doing well, at least we need to keep in our note that VDR of mother is not known. So that subsequently within 3 months, if baby becomes symptomatic because something else, we would know that where the problem is. And most important part of it is easy to diagnose, not very confusing like CMV or toxoplasmosis. Very easy to diagnose the condition. Treponema test and non-treponema test. And both are positive, you are there. And best thing, simple drug. In fact, penicillin is difficult to find in the market these days. It is not like meropenem or azithromycin or any carbapenems or any other sophisticated drugs. Simple drug, which helps in treating the baby, including neurosyphilis. So it is your acumen which will tell you that this can be syphilis. One test and you are done and treat it. That's it. Thank you.
Thank you, sir. Now I request Dr. Ajay Jadhav, sir, to please present the further case on congenital varicella zoster. Dr. Ajay Jadhav is Director, Vatsalya Hospital, Mother and Child Care at Bheed. Over to you, sir.
Okay. I thank Maha IIT especially for giving me this opportunity. Today, good evening everyone. We'll discuss congenital varicella zoster. Is my screen visible to everyone? Hello?
Sir,
Yeah,
it
it's
is
visible.
visible.
Visible,
Presentation
but
is not visible. Yes, it is
Now?
yes,
visible now.
yes, it's visible.
Thank you.
Okay, so good evening everyone. Today we'll discuss congenital varicella zoster. So it is a primary infection with varicella zoster virus which leads to varicella or chickenpox. Since 1995, after introduction of vaccines, epidemiology has been changed significantly. Outbreaks are very common in unvaccinated community. It is basically benign disease in immunocompromised children, but life-threatening in adults and immunocompromised children. Attack rate is 85% after exposure, which is quite high, and humans are the only host. Primary infection with varicella zoster virus leads to varicella, that is chickenpox. If a person who has got varicella previously gets painful skin rash or blisters on skin, it is called shingles or herpes zoster. That is, we call it reactivation of varicella or secondary varicella infection. And breakthrough varicella is an infection with wild-type varicella zoster virus occurring in vaccinated person more than 42 days after varicella vaccination. Pathophysiology and incubation period. Risk in newborn with chickenpox depends on timing of exposure to varicella zoster to immune or non-immune mother, disease onset and time relationship in terms of gestation age. Incubation period is 14 to 16 days and a communicable period is 1 to 2 days prior to exam time till all lesions are crusted. That is usually 5 to 7 days. If exposure to maternal varicella, that is primary varicella zoster, exposure during first or second trimester, infection to mother before 20 weeks leads to congenital varicella syndrome to baby with severe neurological sequelae. In this case, detailed anatomical evaluation is needed. Routine amniocentesis or chordosynthesis is not recommended. If a woman gets affected more than 20 weeks of gestation, then baby gets infantile herpes zoster. Exposure during third trimester to mother. Infection within 3 weeks before delivery leads to severe chickenpox to newborn. If maternal disease manifests more than 5 days before delivery, the risk period of newborn is up to 12 days post-delivery, and the chance of getting chickenpox to baby is 20 to 50%. If the maternal disease manifests 5 days prior to 48 hours post-delivery, then there is very high risk of neonatal varicella because of ascending infection from birth canal, direct contact with lesions, and droplets. If baby develops symptoms within 10 days of life, the neonatal risk of severe disease and mortality is highest in this case. Maternal varicella developing more than 48 hours post-delivery. In such case, neonatal disease is mild because baby is exposed only to respiratory droplets and not transplacental viremia. Maternal exposure to maternal herpes zoster. No evidence to suggest risk of congenital defects to fetus and no neonatal prophylaxis is required if mother has got previous varicella and she has got reactivation of varicella, that is herpes zoster. Exposure to non-maternal chickenpox, that is siblings, a term infant born to seropositive mother is unlikely to develop varicella even if develops it's mild. Infant of a seronegative mother is at risk of infection still it's mild if from non-maternal chickenpox. Importance of antibody in protection against acquisition of varicella zoster virus in newborn. Concentration of anti-varicella zoster virus immunoglobulin in neonate is same as 1 to seropositive mother is same as maternal concentration. Preterm gets lower concentration because of less time for transplacental transfer. The transmission is airborne. The virus spreads from cutaneous lesions and lesser extent by respiratory droplets. Portal of entry and initial site of viral replication is oropharynx. From oropharynx, invasion of local lymph node occurs, which leads to primary viremia, which is of low magnitude, delivering virus to viscera. After several days of virus multiplication, that is incubation period, secondary viremia of greater magnitude occurs, which leads to widespread cutaneous distribution of virus and rash. Cropping of vesicles indicates severe viremic phase. The diagnosis is made clinically, mainly based upon characteristic appearance of vesicular skin lesions in various stages of development and healing. We call it pleomorphism. Pleomorphic rash is there. At the same time, new lesions are there. At the same time, crusted lesions are there. Polymerase chain reaction can be done. It is a test of choice for varicella zoster in patient. It is highly sensitive and specific. There are other tests also which can be done if required, depending upon diagnosis or if baby has got complications. Clinical features of congenital varicella syndrome, that is exposure before 20 weeks. The risk is 2% if infection occurs 13 to 20 weeks, and it is less than 1% if infection occurs less than 13 weeks. The features of congenital varicella syndrome are dermatological features are cutaneous defects, scarring, hypopigmentation, bullous lesions, extremities, hypoplastic limbs, muscular atrophy and denervation, joint abnormalities, absent or malformed digits, chorioretinitis, microophthalmia, anisocoria, central nervous system, intrauterine encephalitis with cortical atrophy, seizures, mental retardation, urinary tract, hydronephrosis or hydroureter, and GI tract, esophageal dilatation or reflux. The picture A shows congenital varicella syndrome with short limb and scarring. The picture B shows skin lesions with congenital varicella syndrome, which are typically depressed, pigmented, and in dermatable distribution. Neonatal varicella, that is infection to baby, infection to mother 5 days prior to delivery to 48 hours post-delivery. The diagnosis is exclusively clinical in neonates with widespread generalized vesicular exanthem and history of maternal varicella or postnatal exposure. Generalized involvement and appearance of different stages of it differentiates it from neonatal herpes simplex virus, which is localized and the lesions are in clusters. So picture A shows pleomorphism, that is maculopapular to vesicular rash with healing with erythematous base. Picture B shows early varicella, which is a dewdrop on the rose petal appearance. And picture C is a herpes simplex, which is early untreated herpes simplex, which also has vesicles, which also has erythematous base, but the lesions are touching each other or kissing, or we call it coalesced vesicles. Complications of varicella can be bacterial infection, that is Staph aureus or Streptococcus pyogenes, cellulitis, life-threatening varicella gangrenosa, necrotizing fasciitis, and neurological complications include encephalitis, acute cerebellar ataxia, meningitis, isolated seizures, and GBS. Management in pregnant women with previous history of varicella zoster or varicella zoster antibody positive, no treatment or prophylaxis is required. Antibody negative mother or woman, varicella zoster immunoglobulin is recommended, but due to shortage, the current recommendations are only to seronegative mother and up to and including 20 plus 0 weeks. Acyclovir is antiviral of choice for potentially severe or severe varicella zoster. It is indicated from 20 plus 1 weeks onwards. Itself has no antiviral action, but it's phosphorylated by enzymes secreted by infected cells, and it forms a DNA chain terminator, which inhibits viral DNA polymerase. In severe varicella, IV acyclovir can be given. Management in newborn, varicella zoster immunoglobulin is given to if maternal varicella manifests 5 days prior to delivery to 48 hours post-delivery. But again, it is not routinely available. If available, it can be given intramuscularly 125 units for more than 2.1 kg to 10 kg and intramuscularly 62.5 units less than or equal to 2 kg. Use beyond 48 hours in susceptible seronegative newborn is controversial but still advocated. All newborns less than 28 weeks or less than 1 kg should receive varicella zoster immunoglobulin exposed to either varicella or herpes zoster. In all cases, varicella zoster immunoglobulin given earlier at the earlier possible at latest 10 days. If not available, then intravenous immunoglobulin at a dose of 400 mg per kg can be used. If neither can be used or available, we can use acyclovir intravenous acyclovir. The dose is 20 mg per kg per dose 8 hourly, which can be given for 10 to 14 days. Oral acyclovir is not recommended as only 1/6 is available. Full-term neonates and infants whose mother are seropositive who develop varicella, acyclovir is not routinely used, but only in selected cases if disease appears to be severe. Chickenpox and breastfeeding. Breastfeeding is encouraged in babies exposed to maternal chickenpox. If lesions are close to nipple, we can give express breast milk until lesions are crusted. Isolation practices and prophylaxis. Isolation depends on whether disease is active or timing of exposure. If disease is active, mother with active lesions must be isolated. Infant is isolated from mother until she is non-infectious. Any baby who develops varicella in NSU should be isolated. Note, a seronegative mother exposed to varicella zoster virus 6 days to 21 days prior to hospitalization should be isolated as she may develop varicella while hospitalized. Her infant, if born term, should be isolated with her. Both should be cared by immunized and separate staff and discharged from hospital at the earliest. No isolation is required if mother who has active disease within 21 days of delivery that resolves before hospitalization. But newborn should stay in mother's room and isolated from other babies. No passive immunoprophylaxis to this newborn. If seronegative mother was exposed within 6 days of admission and discharged within 48 hours, no isolation is needed as varicella would not be expected to develop during hospital stay. NSU exposure. Exposed infants in NSU are usually cohorted. They are isolated from new patients admitted between 8 to 21 days of exposure. Varicella zoster immunoglobulin to all exposed infants with seronegative mothers and all less than 28 weeks or less than 1 kg. Infants who receive varicella zoster immunoglobulin should be isolated from new patients for 4 weeks, around 28 days. If siblings at home at the time of discharge who has got varicella, at the time of discharge of mother and baby from hospital, then one of the following can be done. Send siblings to immune relatives till non-infectious. Mother can return home, baby can stay in nursery. Neonate can be sent to surrogate mothers till siblings are non-infectious. Some experts suggest administration of varicella zoster immunoglobulin to newborn and send baby with mother to home without separation from family members. Varicella vaccination and effectiveness. The varicella vaccine can be given 2 doses, 0.5 ml each subcutaneously at least 3 months apart for the children 12 months to 12 years old. More than 13 years, again 2 doses, 0.5 ml each, 4 to 8 weeks apart. Varicella vaccine's effectiveness, 1 dose gives 82% effective at preventing any form of varicella, and it is almost 100% effective in preventing severe form. If 2 doses are given, these are 98% effective at preventing any form of varicella and 100% effective against severe varicella. So with this, I end my topic. I thank you sincerely to MahaIAP and all the dignitaries. Thank you so much.
Thank you, Dr. Ajay. You are really very crisp and very quick with very valid take-home messages. I request Ashish sir to please share your expert comments.
Yeah, very crisp presentation. Basically, you must have observed that varicella during pregnancy somehow doesn't affect fetus. If it happens within first trimester, the abortion or stillbirth is the thing. But after that, generally, second, third trimester, generally varicella will not affect the fetus. It is at the time of peripartum period, which is 5 days before delivery and 48 hours to 5 days after delivery is a time where the baby is at maximum risk of catching varicella infection. Second part is that if you look at the serology, because the lesions are so clear, at times there is no need to ask for any serological test as far as the varicella is concerned. Why so? Because by the time varicella serology will come with you, it might have progressed to a level where it get into the neurological issues. And we know the herpes zoster, encephalitis and all those, where you got hemorrhagic CSF. We are always concerned about a vesicular lesion in a fetus. It can be a simple blister, it can be a simple staph, and it can be varicella. So moment you find a small vesicle lesion on the skin of a baby, a neonate, you ask for the varicella infection in the mother. At times, genital vesicle lesions also give you the clue that baby might catching infection while vaginal deliveries. So simple, good clinical examination, finding vesicles on the baby and be suspicious about the varicella infection is the method that one need to care and clinical examination. And once it is diagnosed, start the treatment as early as possible. Any baby with lethargy or unexplained seizures and CSF showing hemorrhagic CSF, don't consider there as a traumatic CSF. Ask for the varicella PCR. Without waiting report, start a cyclovir. That's the way to go for. Thank you very much.
Thank you so much, sir.
Thank you, Ashish sir. Moving on further, now I call upon Dr. Bhushan Thorat for the next topic on congenital rubella. Dr. Bhushan, may you please share your slides? Sir, you're muted.
Am I audible?
Yes, you are, sir.
Good evening, all. Myself, Dr. Bhushan Thorat, and thank you to give me such an opportunity to present. First, we start with the introduction. Rubella is also known as German measles or three-day measles or Greek syndrome. It is caused by rubella virus, also called as ruby virus, belongs to Togaviridae family. Its teratogenic property of measles in its infection was documented by Australian ophthalmologist Greek in 1941. We will look for the congenital rubella syndrome. When the maternal viremia with the rubella infection during pregnancy may result in the infection of placenta and fetus. Rubella virus causes the endothelial damage, direct cytolysis, and disruption of mitosis. Rubella infection leads to deranged and hypoplastic organ development, which further results in structural damage and abnormalities. We will see the rubella infection at various trimester. At first trimester, infection leads to abnormalities in 85% of the cases and greater damage to the organs. If the infection is in the second trimester, it leads to defects in 16% of fetus. In more than 20 weeks of pregnancy, fetal defects are uncommon. More the weeks passes, the lesser the chances of congenital rubella syndrome. However, the rubella infection can also lead to the fetal death and spontaneous abortion. Intrauterine infection leads to the viral excretion in the various to 12 to 18 months. We will see the signs and symptoms in the pregnant woman. It is mostly the lymphadenopathy, it is the suboccipital or posterior auricular, maculopapular rash, and joint symptoms. Effects in the fetus, there might be no effects. There might be the death in utero, and there might be multiple anomalies which called as a congenital rubella syndrome. We'll see the defects according to gestational age at the time of infection. If the infection occurs during the first 2 months, the most common manifestation would be congenital cataract and glaucoma. In the first trimester, we'll see congenital heart defects. In the 4th month, there will be cognitive defects and a deafness. In the 5th month, there will be salt and pepper retinopathy. Clinical manifestation. There will be a PDA, nuclear cataract, sensory neural hearing loss. It's also known as a Greek triad of congenital rubella syndrome. The most common manifestation among these all three is a sensory neural hearing loss. The most common heart defect is a PDA, followed by peripheral pulmonary stenosis, followed by VSD, followed by ASD. The important manifestation includes the blueberry muffin rash, salt and pepper retinopathy. The manifestation can be classified into 2 types: early manifestation and late manifestation. Early manifestation include deafness, cardiac defects, cataract, retinopathy, microphthalmia, hemolytic anemia, thrombocytopenia, purpura, petechiae, hepatosplenomegaly, hepatitis, IUGR, microcephaly, bone lesion, and meningoencephalitis. In the late manifestation, we'll see hearing loss, intellectual disability, which include autism, ADHD, all, diabetes mellitus, thyroid dysfunction, extramedullary hematopoiesis, and progressive rubella panencephalitis. We can see the classical blueberry muffin rash in this baby. This is the congenital cataract, which is a nuclear cataract. This slide shows the salt and pepper retinopathy. laboratory studies in the mother. A diagnosis made by the positive serological test of IgM antibody or IgG seroconversion or fourfold rise between the acute and convalescent IgG titers. Virus culture is taken from the nasopharyngeal swabs. RT-PCR is used to confirm the culture results or to detect the viral RNA directly. Laboratory studies in the fetus, the detection of virus in amniotic fluid, rubella specific IgM antibody in fetal blood, RT-PCR of fetal blood or chorionic villus biopsy specimen. Laboratory studies in infant, the persistence of rubella specific IgG infants after the 6 to 12 months suggests that congenital infection. Rubella specific IgM antibody also indicate the infection, but false positive IgM results can occur. Specimen for virus detection. We take the specimen from nasopharynx, urine, CSF or buffy coat of blood or conjunctiva also. Nasopharynx samples are the best sensitivity for the culture among all these. In the CBC, we see the differential hemolytic anemia. There's a low WBC count and low platelet count, that is leukopenia and thrombocytopenia. CSF analysis shows the increased protein to cellular ratio. X-ray, when we do an X-ray of long bones, we see a metaphyseal radiolucencies. Treatment. If the infection occurs before the 18 weeks, there is a high risk of infection to the fetus, and fetus develop the severe symptoms. The termination of pregnancy should be considered because the severity is more. If the prenatal diagnosis is not confirmed, a specific pediatric exam must be performed in newborn, including the rubella virus IgM assay. If the infection occurs after 18 weeks, the pregnancy could be continued with the simple ultrasound monitoring. A specific pediatric examination of the newborn should be done, and the testing of the rubella virus IgM are recommended. Management of neonatal rubella. There is no specific treatment for the rubella. In the rubella, breastfeeding is not contraindicated. The management is mainly a supportive and aimed at addressing the specific problem, including developmental, sensory, endocrine, and cardiac problem. The regular assessment, 3 to 6 monthly, is necessary in the first few months or year of the life to detect the emergence of late abnormalities. Thank you.
Thank you, Dr. Bhushan. That was really crisp and clear. Now I request Dr. Om Prakash Jamadar sir to give his expert comments.
It was Bhushan. So, congenital rubella syndrome, I am sure that is preventable condition. If you take the vaccination, then the chances of having congenital varicella will be very, very big. So, the problem that the baby faces, the stage of infection. I may stop my video so that it is clearer. So, at what stage of life baby gets the infection, that decide the changes that are going to happen during the stage of organogenesis part. So, first trimester are going to cause significant number of abnormalities, and that is what we see the typical triad if the infection happen in the first trimester of the pregnancy. And as the pregnancy progresses and infection happens later, the complication will be that the salt and pepper retinopathy is the mildest form of retinopathy, but it can progress. It is not that initially the problems are not there, but they can progress over a period of time. Many a times, we miss to look at the baby, newborn babies, as well as subsequently on follow-up. Any these developmental delays, we should look at the overall picture, because it may be a progressive condition where the cataract and glaucoma are developing. And any patient with a persistent PDA coming later part of the life, you should look whether there is a component of congenital rubella syndrome and look at the triad. So that is what sensory neural deafness also, many times they may not be there at the time of birth, but it may progress further. So again, any child with sensory neural deafness, think of congenital infection. CMV is one of the commonest in the contributing factors, as well as the congenital sensory neural deafness. And as far as the blueberry muffins rash is concerned, this rash can happen in other congenital infection. So this basically tells there is a extra other than the marrow and the liver and the yolk sac, there is other extra medullary erythropoiesis is happening. That tells us that there is involvement in bone marrow. That is the sign that also implements thrombocytopenia, anemia. All these problems are common in the baby with congenital infections, and blueberry muffin rash is an indirect marker of that. And that is how we can clinically the finding as well as the possible effects of the infection for these babies. And laboratory diagnosis is again the serological markers that we do, IgG and IgM markers. As PCR is the most sensitive. And as far as treatment of congenital rubella is there, I have seen babies at 8-9 months of age with cataract, and then later diagnosed with PD, and then require PD ligation and all that. Means it's more of a supportive care that is can be done in case of congenital rubella syndrome. So again, to emphasize, we need to take care of the vaccination to prevent this problem, and it is very much preventable problem, we'll say. Thank you, Dr. Bhushan, for the nice presentation.
Thank you, Dr. Om Prakash, sir. Moving on further, I call upon Dr. Shilpa Kalane. Dr. Shilpa Kalane is Chief Neonatologist, Dinanath Mangeshkar Hospital, Pune. Over to you, madam.
Thank you so much. Good evening, everyone. Thank you for giving me this opportunity to prepare such a complicated topic. I really enjoy preparing this topic. Okay. So,
Dr. Shilpa, can you be a little louder?
Yeah. 1 second. Just give me 2 minutes. Now is it okay? Now, am I audible?
Okay. Yeah, maybe you could increase the volume of your mic, if possible.
Yes. Now it is okay?
Little bit better.
Okay. So we are aware that congenital CMV infection is the leading cause of sensorineural hearing loss and can cause other long-term neurodevelopmental disabilities. In NICU, if symptomatic, it may mimic sepsis, and this is how it poses challenges in further investigations and management. So today I will try to demystify following aspects related to congenital CMV, that is, whom and how to investigate, when and how to treat, and how to monitor these babies during treatment and after treatment. So investigations for CMV should be done in newborns with signs and symptoms on neuroimaging consistent with congenital CMV. Also in newborns with documented sensorineural hearing loss and those born to mothers with known or suspected CMV infection. It is also to be considered in neonates, immunocompromised neonates, because this can have devastating effect in these babies. Clinical features in symptomatic neonates are similar to those in other congenital infections. Neonates may have isolated or constellation of findings, jaundice, petechiae or blueberry muffin rash, hepatosplenomegaly, microcephaly are relatively common clinical findings. Please note, sensorineural hearing loss is a common sequelae which may be detected at birth, but in 18 to 30% has delayed onset. CMV is said to be life-threatening when it presents as sepsis-like illness, myocarditis, HLH, or other severe end organ damage. This is very important because our further treatment is based on whether the illness is life-threatening or non-life-threatening. Abnormal neuroimaging specific to congenital CMV infection is periventricular leukomalacia, lenticular striate vasculopathy, as you can see here, periventricular calcifications, you can see here the periventricular calcification, very classical of CMV, and migration abnormalities, if not explained by any other cause. Laboratory diagnosis is accomplished by isolation or molecular detection from urine or saliva. Although saliva is easier to collect, false negatives and false positives are common with saliva. Testing blood sample is not recommended as all infected babies may not be viremic. Viral culture, modified culture like shell vial culture, and PCR are the preferred diagnostic tests. PCR is more sensitive compared to shell vial culture, though it is rapid. It is also accurate when it is concerned with the sample traveled from the collection center to the investigation center. Also, it provides quantitative results. Serological testing, please note, serological testing that is in the form of IgM is not recommended for diagnosing congenital CMV infection. If the virus is isolated within first 3 weeks, it is labeled as virologically proven congenital CMV infection. If it is detected after first 3 weeks up to 1 year, then it is labeled as possible congenital CMV infection, or postnatally acquired CMV infection. If the CMV virus is not detected, then the neonate is not infected. Infants with virologically confirmed CMV infection should be evaluated for evidence of organ involvement. Also, before we start the treatment, to monitor further, we should have baseline function as well as to monitor further for the response to the treatment as well as the adverse drug event. So this includes thorough physical, neurological, neurodevelopmental evaluation, including anthropometry, CBC, LFT, RFT, coagulation profile in specific situations if there is hepatitis or disseminated illness, hearing assessment, not by OE, by brainstem evoked audiometry, ophthalmology, and neuroimaging. The decision to treat an infected infant with antiviral therapy is based on severity of symptoms. Treatment is indicated in infants with moderate to severe symptoms, means those with CNS disease not explained by any other cause, or those presenting with life-threatening disease, or infants with multiple abnormalities. Like I just showed you all the symptoms. It's not one symptom. If there are multiple symptoms, then we may have to treat these patients. Infants with mild symptoms or those with isolated sensorineural hearing loss, the treatment should be considered on case-by-case basis. Treatment, once indicated, it should be initiated within 30 days of birth, as it will give better outcome in the form of neurology and hearing. Antiviral treatment is not recommended for asymptomatic congenital CMV infection. Once the treatment is indicated, before we start treatment, assess the baby for two things. One is stability, and second is whether the baby is able to tolerate feed or accept feed. If the baby is stable and tolerates feed, there are only two treatments which we consider: valganciclovir and ganciclovir. Valganciclovir is considered if the baby is stable and tolerates feed. The dose is 16 mg per kg per dose, given 12th hourly. If the baby is not stable or does not tolerate feed, then the treatment is ganciclovir, which is IV. The dose is 6 mg per kg per dose, 12th hourly. Valganciclovir is prodrug of ganciclovir with relatively lesser side effects. Hence, whenever possible, whenever the baby's condition allows, switch from ganciclovir to valganciclovir. And ganciclovir, due to its side effect profile, should not be administered beyond 6 weeks. Once treatment is initiated, monitor these infants for two things. One, response to treatment and adverse drug reactions. For monitoring the adverse drug events, we need to do CBC, LFT, and RFT initially twice a week. Once the baby is stable, then weekly. And to monitor response to the treatment, CMV DNA PCR is advised. If there is toxicity seen, then the lab needs to be monitored frequently, that is every 1 to 3 days. In case of non-life-threatening CMV disease, the CMV DNA PCR is done at 3 months and 6 months. If the disease is life-threatening, then the CMV DNA PCR is advised to be done weekly initially and then at 3 months and 6 months. If there is a good response to the treatment, which will be defined as clinical improvement and declining CMV DNA levels, so then the treatment is continued. Of course, we monitor toxicity. The total duration of treatment is 6 months. And the end point is no detectable virus in urine CMV PCR. If there is no response, please see whether the optimum dose has been given. Also, side by side, try to rule out antiviral resistance and whether the baby has underlying immunodeficiency. If the toxicity or adverse drug events are encountered, then hold the treatment. Monitor the baby for CBC, LFT, and RFT to be done every 1 to 3 days. When the reports normalize, then restart the treatment. So the outcome depends upon clinical pattern of disease at birth as well as antiviral treatment provided. In long-term follow-up studies, late sequelae included sensorineural hearing loss, intellectual disability, microcephaly, strabismus, and so on. All children with congenital CMV infection should be followed throughout childhood and into adulthood for evidence of long-term effect of CMV. So hearing should be assessed every 3 to 6 months during first 3 years of life. Annually thereafter until at least 18 years, eye checkup should be done annually and developmental follow-up as per NNF guideline. So take-home message is congenital CMV is the leading infectious cause of sensorineural hearing loss and neurodeficit worldwide. Diagnosis can be made by isolating virus in saliva or urine within the first 21 days of life. Symptomatic congenital CMV should be treated with ganciclovir or valganciclovir for 6 months to achieve better outcomes. Early treatment within 30 days reduces the long-term neurodevelopmental sequelae. There is insufficient evidence for treating asymptomatic or mild congenital CMV infection. I have not touched upon this topic, but universal infant screening is not yet advised. Thank you so much. I'm happy to take any questions if there are. These are few clinical pictures of the rash, microcephaly, and periventricular calcifications. Thank you.
Thank you, Dr. Shilpa. This was really a pictorial presentation. Over to you, Dr. Jamadar, sir, for your expert comments.
Yeah, very nice presentation by Dr. Shilpa. So CME is one of the commonest congenital infection that we may face. In fact, the incidence in Indian scenario is not much documented, but in Western world also it is one of the commonest. And manifestations may be asymptomatic to completely symptomatic. So if you look at the evaluation part also, it's not that we should have a high suspicion before we think of evaluation. And one of the high suspicion that we should think about CMV is any child presenting with a sensorineural hearing loss. So these are the cases where we should think highly that there is a possibility of CMV infection. And babies having born to mothers who are having suspected CMV infection, those are immunocompromised status. Now, clinical finding wise, the overall picture, if you look at all this congenital infection, maybe some overlapping signs symptoms are there. But in CME, typically what we see is periventricular calcification. That is very prominent finding. If you see the other toxoplasma and all that thing, there are diffuse calcifications. Even the Zika virus, there are subcortical calcification, but periventricular calcifications in the CNS finding is very specific for the congenital CME infection. And again, as far as the evaluation investigation is concerned, if the CME virus is detected in all it can be detected in all secretions, urine, saliva, blood, and everywhere. If that is there in the first 3 weeks of life, that means there is a proven congenital CME infection. However, afterwards, if it is there, we are not in a very clear situation. However, along with the detection, if there are some symptoms, then there is a possibility of CME infection. And if the virus is not detected, that means there is no any chances of infection. Now, as far as the management part is concerned, there are oral medications, as Dr. Shilpa explained nicely, ganciclovir and valganciclovir, which are different preparations. So oral valganciclovir as well as ganciclovir, both are equally effective. What is the barrier that we face many times is a prolonged treatment, somewhere around like 6 months of treatment. And we need to monitor the side effects profile of all these medications in terms of monitoring the liver function test, renal function test, including the coagulation profile, as well as the leukopenia that we can see with these medications. So that is the major barrier that we may face. And it's not that we just treat, we need to follow up the consequences, because again, in the sensorineural hearing loss, which may not be present initially, but that can progressively develop. And many times we can see a unilateral sensorineural hearing loss also in these situations. So we need to keep a track of that also. So we need a multidisciplinary team where the developmental pediatricians are also involved, because all these babies with congenital infections are very at high risk of developmental delays. So it's a MDT team that is what is required. So that is what I will say. So we need to have our eyes and ears open whenever we think of congenital infections. Any baby with congenital cataract, any baby with sensorineural deafness, IUGR babies, and developmental delays babies, we should think of TORCH group of infection in these situations.
We are open to audience questions. We have Dr. Meenakshi here with a few questions. May I take them up, sir? The question is, any comment on rubella PCR of urine? Second is isolation of NICU babies with respiratory symptoms with positive urine PCR. Third is exposure of pregnant women with rubella PCR, positive babies, any guidelines? Any of the experts may take this question. Dr. Ashish sir or Dr. Om Prakash sir? Dr. Ashish sir, may you please unmute?
Can you repeat the question, please?
Any comment on rubella PCR of urine? The first question.
Generally, rubella has not been picked up in the urine. It is picked up in the serum itself or CSF. Generally, it is in the serum.
Isolation of NICU babies with respiratory symptoms with positive urine PCR.
For which infection?
I guess it's rubella only. This was in context to rubella.
I don't think that isolation is required for the rubella.
I think it is.
And the third question is,
hello.
Chickenpox, we need to be careful because that is one thing which can spread very fast. So we need to be careful as far as the, you know.
The third question is exposure of a pregnant woman with rubella PCR positive babies, any guidelines?
Very weird question, but because see, it is not the baby is going to be infective. Babies, these are not the droplet infections or the airborne infections. It can spread to the surroundings or to the caretakers. So for PCR positive rubella baby fetus for the baby will not be of any problem to the mother or the surroundings. It is the varicella, rightly said, is the one RSV. All these are the one which are responsible for the spread of infection, nursery or the.
Dr. Meenakshi, are you there? Dr. Meenakshi?
Yes, ma'am.
May you unmute yourself and ask your question? Also on congenital.
Yes, sir. Actually, sir, I asked this question since there are certain articles, such as an NCBI article also, which suggests that children with congenital rubella syndrome should be considered contagious until at least 1 year of age, unless 2 negative cultures are obtained. So many times, like in our NICU, since we must have had exposure of a pregnant nurse, and there is a baby with nasopharyngeal, urine, or serum rubella PCR positive. So that was the question in that context. Sir.
I don't have any idea about isolating rubella baby from the surroundings and from the caretakers.
Okay.
Sir, one question. If as a pediatrician, antenatally, if somebody comes to us with an advice of regarding termination of pregnancy in any of these exposed infections, so what would be your take on each of these individually, all these 5 individually?
None of the infection is indication for termination of pregnancy from it. If detected in time, mother can be given medication so that the fetus can be saved. If you take right from the first toxoplasmosis, maternal treatment is available. Syphilis, difficult to pick up in the fetus. Generally, it is a postnatal diagnosis. That also generally after 1 month of the first 1 month of the life. At birth, congenital syphilis is not detectable. It appears after 2nd or 3rd month and mostly before 6 months. You talk about varicella, yes. Varicella, as I told earlier, getting infected in the peripartum period. So mostly if mother has got chickenpox within 5 days before delivery and 48 hours after delivery, then baby is at risk of getting chickenpox. So intrauterine chickenpox is not possible. And as we already said, rubella, yes, intrauterine infection is there, CMV intrauterine infection is there. Out of 100 pregnancy, 10% pregnant woman will be CMV positive in any country, including India. But that does not mean that baby is infected. Out of this 10%, only 10% will be symptomatically transmitting disease to the baby. So in all, out of 100, only 1 baby will be infected because of the maternal CMV infection. And that also in the first trimester, generally abortions for the stillbirths. Later on, we get the typical symptoms, and that can be picked up and treated.
Many a times they are asymptomatic at the time of birth. If
Yeah.
you see all the list of presentations, they may progress later, and then we pick up maybe some developmental delays, their failure to thrive, prolonged jaundice. So these are the indirect manifestations. So they won't land into early, in utero diagnosis, and then abortion in early stages. Maybe we need to be vigilant if there is a history of repeated abortions. That may tell that there is some contributing factors are there in that situation. We need to be vigilant, but they can't become indication for abortions in first trimesters.
If you get amniocentesis, get PCR toxoplasmosis, yes, but as I told you, it is treatable.
Yes.
It never becomes the indication to terminate the pregnancy. Not a single torch infection, including HIV, is indication to terminate the pregnancy.
Any of the audience would like to ask any questions? It's open to the experts. Dr. Bhavesh sir.
CMV is another one interesting topic. Those who are working in the NICU and those looking at the small babies. In our country, the blood transfusion or the red cells are never CMV filtered. So whatever blood that we get is not CMV screened. And our babies are likely to develop CMV infection because of the transfusions. And once transfused, immediately baby is not going to show the reaction. So when you look at the baby after 3 to 4 months in OPD and has got history of transfusion, you have got some clinical things going on which is not relating to, or which is not correlated to the present symptoms, then you can think of CMV infection, investigate. If symptomatic, that is to be treated. And this most common kind of CMV that we face in our day-to-day practice, maybe 2 cases or 3 cases a month, a year, we get where the baby is not thriving well, has got unexplained thrombocytopenia, has got prolonged jaundice, has got HS megaly. And the moment you pick up the CMV, treat, and they are all fine.
Another interesting fact about CMV is like, any baby stuck on ventilator for prolonged time, you are not able to come to any consensus conclusions. You can think about that pneumonitis is contributing by the CMV. So that also is one of the differential that we should keep in mind.
Yep.
Dr. Bhavesh, you want to add something?
No, I think it's an excellent discussion and it's a learning point for all of us. There are certain guidelines which Dr. Meenakshi was suggesting about the congenital rubella syndrome baby, congenital rubella syndrome infant. So CDC says a guideline that these babies are to be considered infectious till their age of around 1 year. They keep shedding these viruses till up to first 3 months, but they can do it even up to 1 year and probably beyond that.
Okay.
The challenge is with us that we may not be able to diagnose early, and very rightly that if we have a suspect, then probably we need to keep the nursing care staff who are pregnant or potential pregnant to be at least away from that baby for the at least first trimester, because that is the time where they are at high risk of catching the congenital rubella syndrome complication. But the challenge is to early diagnose.
Thanks.
But it's excellent discussion, and I think we all are learning from everyone, and this kind of a topic will keep revising us our old torch infections, because we don't see it very often and we tend to forget so many things. So thanks to all the speakers and all the experts to give really insightful of the take-home messages, and hope to keep learning from you throughout this year. Thank you so much for everyone giving
Actually, we need to thank
Sir,
you,
can I
sir,
add
for
a
the
point?
topic.
Yeah, Dr. Meenakshi.
Yes, sir. So actually, sir, I work as a pediatric infectious disease specialist in Vadia Hospital, Mumbai. So actually, we have had cases where we are suspecting the baby had hepatosplenomegaly and blueberry spots plus a pneumonitis kind of picture. So when we send the nasopharyngeal PCR, it came positive for rubella, and we had pregnant nursing staff working in that area. So at that time, we researched a lot on isolation of these babies because it can be very much harmful for those pregnant women. And also for CMV, there are differences in European and American guidelines regarding for asymptomatic CMV. As Sir had mentioned that there is always a risk of developing CMV acquired hearing loss later also. So I think there are, the French guideline says that we treat the CMV even if it is asymptomatic or mild. Also, we do a CSF, CMV, PCR, and but treat congenital CMV. So there are certain differences in those guidelines also. Thank you.
Compliance is one thing which is very difficult with all this CMV infection.
Yeah,
It's like too long treatment,
CMV, the well-studied parameter is only CMV with moderate to severe symptoms. The other guidelines about mild symptoms or asymptomatic CMV or isolated sensorineural hearing loss. Yes, there are individual observational report plus the retrospective data saying that when treated, the outcome is better in terms of hearing. But we do not have proper well-designed RCT or the good evidence. That's what I mentioned. There's insufficient
Yes.
evidence to strongly comment on treat or not treat, because the medicine itself is toxic.
Yes.
So it has to be discussed with parents about pros and cons of treatment, benefit, and the compliance with the treatment. So
Yeah,
also
so I must say Dr. Bhave's comment about CDC, I fully agree with what is there. But again, little bit controversial because the baby at what stage is getting rubella, how the shedding will happen. Still, it is not very well studied. So as a general, they say that better isolate a pregnant woman from keeping away. But again, the gray areas between the various guidelines, and that is why we are little bit on the away from the isolating those babies. You may keep your pregnant staff away from the index case. But isolating these babies, I have my own doubts, but we have to follow the guidelines. I must say that.
Thank you. Thank you, everyone. This was an excellent discussion. Now I request Dr. Manjusha Madam to please take over the further proceedings.
Yes, thank you, Grivita, so much. Indeed, it was a really excellent discussion, enriching discussion, and for congenital infections, very useful. I express my sincere gratitude towards the entire supporting team who all made this first event of Wednesday Wisdom a grand success. Thanks, Dr. Ram Gopal sir and Dr. Amol sir, for your rock solid support in organizing today's program. Thanks, respected Dr. Singara Velu sir, for joining and guiding us. Your presence was truly enriching for us. Thanks, Dr. Sanjay Aher sir, for your gracious presence and guidance. Thanks, Dr. Milind Bapat sir, being MMC observer. Thank you, Dr. Ashish Mehta sir and Dr. Om Prakash sir. Special thanks from Maha IIP office, IIP Women Committee, to both these experts for your excellent efforts for checking the presentations of our speakers and correcting them. You took a lots of efforts for the best final take-home messages in managing the congenital infections. Thank you so much, Dr. Ashish sir, Dr. Om Prakash sir.
Thank you very much. Thanks a lot. Thanks for the opportunity.
Yeah, your presence in the success of journey of today's Wednesday Wisdom really means a lot to us, sir. Thank you.
Thank you.
Hearty
Before we
congratulations.
conclude, I must say the journey has started in the womb. So
Yeah,
we
yeah.
have to continue it
That's
further.
why we have started the journey of Women Committee from the womb itself. Now we are
Yes,
going from top
very
to bottom. We'll see
Yes,
subsequently.
yes.
Thank you. Hearty
Thank you for the
congratulations,
opportunity.
dear
Thank you.
all
Thank you so much.
dynamic speakers, for your excellent presentations and contributions in the success of today's webinar. Congratulations, Dr. Tanushri Mukherjee, Dr. Deepa Joshi, Dr. Ajay Jadhav, Dr. Bhushan Thorat, and Dr. Shilpa Kalani. Thanks, Dr. Jitu sir and Satish sir, for your gracious presence. Thanks, Dr. Bhavesh sir, for your scientific contribution for the webinar. Thanks all the respected seniors and colleagues for joining today's webinar. Thanks my dear friend Dr. Grivita being the wonderful co-host to me, and Dr. Amruta Bhaviskar for supporting and organizing the event. Thanks my zonal women committee members for your consistent support and presence, and same we expect in near future. A big thank to respected Pallavi ma'am for your valuable digital support as always. Once again, thanks all the viewers for joining today in huge number, almost reaching 300. Thank you so much. Friends, knowledge without wisdom has least value, says respected Dr. Abdul Kalam. Let us get enriched by joining next Wednesday Wisdom will be scheduled in the next month. Till then, take a very good care of yourself and your patients. Thank you. Thank you so much.
I'd like to
Here I
thank you as well, Manjusha Madam. You have been continuously behind the program since a long time. You've really taken a lot of efforts.
Yes, thank
Appreciate
you.